now. Okay, great. So, I mean, just a brief introduction, just in case somebody doesn't know who you are. You already mentioned that you are a cardiologist and you work in the University Clinical Center of Serbia in Belgrade. And yeah, I will give you just a word and you can go ahead. Yeah.
Okay, first of all, thank you very much for inviting me to be part of your Open Journal Club. It's really a pleasure to be with you and to talk to you. So I'm a cardiologist and I'm working in the University Clinical Center of Serbia in Belgrade. I'm also associate professor of internal medicine and cardiology at the Belgrade Medical Faculty. And considering and regarding my cardiology job, I'm working both also as an interventional cardiologist and also as also doing non-interventional cardiology, mainly also echo. So I'm doing both. And okay, so if this is sufficient, I would then like to start with the presentation, if it is fine with you.
Yeah, and, sure.
And okay, let me present you the AVATAR trial results and implications for further clinical practice. For some reason, my slides are okay. So this is my conflict of interest slide. Decision to operate on an asymptomatic patient with severe aortic stenosis and with normal left ventricular function remains a matter of debate and still is a significant unmet clinical need. Observational studies challenged the watchful waiting strategy in asymptomatic patients with severe aortic stenosis by reporting increased mortality and morbidity. And the recent randomized trial suggested the benefit of early valve surgery, but in highly selected patients with critical aortic stenosis and high prevalence of bicuspid aortic valves. The objective of AVATAR trial was to evaluate the safety and efficacy of early surgical aortic valve replacement in asymptomatic patients with severe aortic stenosis and normal left ventricular function. AVATAR trial was physician-initiated, prospective, multi-center, randomized, open-label trial in which patients with asymptomatic severe aortic stenosis were randomized either to elective surgery arm, which implied early aortic valve replacement, or conservative treatment arm, which implied watchful waiting strategy with guidelines-directed management of comorbidities. As shown here in this map, the trial has been performed in 9 medical centers across 7 European countries. We have included patients who were older than 18 years, who had severe aortic stenosis defined according to standard echocardiographic criteria, patients who were without symptoms as confirmed by negative exercise testing, and patients who were mainly at low risk for surgery as defined by a Society of Thoracic Surgeons score. On the other hand, we have excluded patients who had positive exercise testing, who had impaired left ventricular ejection fraction at rest, who had very severe aortic stenosis, defined as a maximum velocity above 5.5 meters per second, patients who needed additional ascending aorta replacement, patients with previous CABG or any previous heart valve surgery, patients with major comorbidities, and patients who had reduced life expectancy. The exercise testing was mandatory and was performed according to standardized protocol. The test was considered negative only if patients reached the age predicted to maximal heart rate. The test was considered positive if there was onset of aortic stenosis-related symptoms, if there was fall in systolic blood pressure, more than 20 millimeters mercury from baseline, or if there were any signs of myocardial ischemia. The primary endpoint of the trial was composite of all-cause death and MACE, comprising of acute myocardial infarction, stroke, and unplanned heart failure hospitalization requiring IV treatment. Secondary endpoints included in-hospital mortality, repeated MACE, time to death, time to heart failure hospitalization, or safety readouts such as major bleeding according to BARC criteria or thromboembolic complications. The trial had event-driven design. It targeted 35 events, assuming need for 24 months enrollment of total of 312 patients. And here is the trial flowchart. So we have assessed 197 patients for eligibility, of which 40 were excluded, either because they were not meeting inclusion criteria or because they have declined to participate. Finally, we have randomized 157 patients. 79 were allocated to the conservative treatment and 78 were allocated to the early surgery. All randomized patients have been included in the primary intention to treat analysis. We have also performed the additional analysis in which we excluded 6 patients who were randomized to surgery, but eventually did not receive one due to the reasons shown here in this box on the right side. And here are the baseline characteristics of our patients. So, as I already mentioned, we had included patients who were at low risk for surgery. As you see, the mean STS score was 2.1. Also, patients with mainly degenerative etiology of aortic stenosis, and patients who had normal left ventricular ejection fraction. With regard to other baseline characteristics, they were pretty well balanced between the groups, and also including the use of standard medications. The follow-up was per protocol every 6 months, and number of pre-specified events was reached in October 2020, and accordingly, the DSMB recommended us to stop the enrollment on November 1st, 2020. Overall median follow-up was 32 months, 28 months in the early surgery group, and 35 months in the conservative treatment group. This is the table of the components of the primary composite primary endpoint. And as you see here, there were a total of 39 composite primary outcomes, 26 in the conservative group and 13 in the early surgery group. And the main difference in the composite primary outcome came from the difference in the all-cause death and heart failure hospitalizations. The acute MIs and strokes were well balanced between the groups. Operative mortality in the early surgery group was 1.4%. And this is the main figure of our trial, showing the results of the composite primary outcome. So showing the incidence of the composite primary outcome between the two randomized groups. Blue dashed line represents patients randomized to early surgery, and red line represents patients randomized to conservative treatment. And obviously the difference was statistically significant, favoring patients randomized to the early surgery. And it seems that the difference was starting to be seen approximately 10 to 11 months after randomization. We have also performed additional analysis in which we have included 6 patients who were randomized to surgery but were not operated. However, the results and the p-value were very consistent with the primary intention to treat analysis. We have also performed the analysis of individual secondary endpoints, including all-cause death on the left and heart failure hospitalizations. And also in both cases, there was a trend favoring patients in early surgery group, but in both cases, it did not reach statistical significance. We have also performed the additional analysis, the comparison of combined all-cause death and heart failure hospitalization. And the incidence of combined all-cause death and heart failure hospitalization were significantly lower in patients randomized to early surgery. Now, although this analysis was a post-hoc analysis and was not pre-specified, we believe that this combined outcome underlines the importance of composite primary outcome, as well also as might be informative for the future design of future trials in a comparable clinical setting. We have also performed the heterogeneity analysis, in which we have chosen several subgroups, and subgroups was selected based on their clinical significance. and without having access to outcome data. And individual parameters were dichotomized by median value, except for age, where the cutoff was 65 years, and ejection fraction, where the cutoff was 60%. And in all subgroups, in all cases, we have found no significant heterogeneity, meaning that the results of the trial were homogeneous across the different subgroups. And this is the table showing the total MACE components. We had a total of 49 MACEs, 33 in conservative treatment group, 33 in conservative group, 16 in the early surgery group, and the difference was still significant. Again, the main difference came from the difference in all-cause death and heart failure hospitalization. Although there was a slight increase in the number of acute MIs in conservative group, and also a slight increase in both groups with regard to strokes. And we have also compared the incidence of serious adverse events. And again, we have observed that there was a trend favoring patients randomized to early surgery, but it did not reach the statistical significance. And with regard to the secondary endpoints, we have analyzed all others, of course, and secondary endpoints and compared them between the groups. We didn't find any statistically significant difference in any of observed parameters, including intraoperative mortality, repeated MACE, or safety readouts such as thromboembolic complications or major bleeding. So, in summary, our trial is the largest randomized trial, closely reflecting the clinical dilemma of a low-risk, truly asymptomatic patients with severe and mainly degenerative aortic stenosis and normal left ventricular function. Early surgery was associated with lower incidence of primary composite outcome, comprising of all-cause death, acute myocardial infarction, stroke, or unplanned heart failure hospitalization. And consistent with primary outcome, repeated MACE or combined all-cause mortality and unplanned heart failure admissions were lower in early surgery group as compared to the watchful waiting group. And intraoperative mortality in early surgery group was in line with anticipated mortality for elective isolated surgical aortic valve replacement. And in conclusion, the AVATAR trial demonstrates the preliminary efficacy and safety of early surgical aortic valve replacement in improving clinical outcome in patients with asymptomatic severe aortic stenosis and normal left ventricular function. The findings advocate for early surgery once aortic stenosis becomes significant, regardless of symptoms. Thank you very much, and thank you for your attention.
Thanks very much, Marko. Matteo, if it's okay, maybe I'll start with the first question. Great presentation, great paper, which is obviously going to have a lot of influence on the next valve guidelines that are going to be produced. I had two questions. As you know, Raphael Rosenheck from Vienna has published many studies basically saying that asymptomatic aortic stenosis is not a bad actor and we don't need to do anything about it. How do you compare your event rate in the control group to Rosenheck's studies that he's published in the New England Journal of Medicine, etc.? My second question is, there's several trials ongoing right now around the world comparing TAVI to conservative management in asymptomatic aortic stenosis without a surgical group as a comparison, which, you know, of course, now with your trial, with AVATAR, you would argue strongly that ethically there should be a surgical group involved as well in those trials. But I just wanted to hear what your opinion of that is, Marko.
Yes, well, with regard to your first question, indeed, the perceived mortality or risk of sudden cardiac death in the asymptomatic patients is perceived to be low and is usually taken to be around 1%. And in our study, it was somewhat higher, so it was a little bit above 2%. However, you had several data, and a couple of them pretty recent one, which also showed that this incidence of sudden cardiac death is probably higher than this 1%. And it's difficult to claim which is the most precise number, but we can say that this asymptomatic severe aortic stenosis is not a benign disease. So it does have a mortality, even if we take it 1%, which is at least to some extent questionable, this 1% per year, it's still higher than in general population. So with regard to that, and also there is with that risk of sudden cardiac death, there is also a risk of structural and functional changes in the myocardium while waiting for some future aortic valve replacement. And by the time that aortic valve replacement comes, those changes might be already irreversible. So you can perform excellent procedure, you can do excellent surgical or percutaneous procedure, but the quality of life after this procedure might be suboptimal. So also another thing to be considered when thinking about possible early intervention. And with regard to the ongoing trials, yes, probably the only trial that is ongoing with regard to at least the time on randomized trial that is ongoing, it is setting with the TAVIs is early TAVI. And we did have last month one retrospective analysis as a subgroup of the evaluate low risk trial, and they have published the comparison of 130 patients who were randomized in the evaluate low risk trial who were asymptomatic. And the results, the follow-up was 1 year. They have shown that TAVI was non-inferior to the surgical aortic valve replacement. Now, we shouldn't jump to any conclusions. It's too early. It does give some hints. However, we should wait for the thorough results to be sure that TAVI is correct and applicable procedure in those patients. However, even if TAVI, early TAVI trial comes positive as a result, and they show that TAVI is beneficial in those asymptomatic patients comparing to the conservative treatment, I still think, as a cardiologist, that the gold standard in these patients is surgical aortic valve replacement, because these are mainly younger patients, low-risk patients without significant comorbidities. So, with regard to that, if early TAVI comes with positive results, I think we should have a randomized trial comparing surgical versus percutaneous procedures in those patients, in those subgroup of patients. Because don't forget, we are here talking about only a subgroup of asymptomatic patients with severe aortic stenosis. So patients who are at low risk for surgery, who do not have significant comorbidities, and who don't have any significant other issues that might be involved with the outcome of these patients. So I think in the future, maybe in the near future, we should have some randomized trial comparing surgery to TAVI in those let's say middle-aged patients. And it's gonna be a totally different story comparing to TAVI versus TAVR trials in symptomatic patients. I think so. First of all, this is going to be a much younger cohort, much younger from the medical point of view, and it's not going to be. I think at least it's going to be so convincing in any direction, because I think surgery is still in those patients, you know, a very good option, very good option.
Thank you, Marko. Are there any, are there any other questions from anybody else?
I do have a question. You kind of already answered it, but when I was looking at your tables, I saw that the left ventricular end diastolic volume was kind of big. The patients were asymptomatic, the left ventricular function was good, but the left ventricle was already bigger or not normal. Do you think this explains maybe your observed results? And do you think it might be like putting down the indication for surgery, like even operating patients without symptoms before the ventricle becomes too big? I mean, what's your opinion on that?
Well, of course, we do have some parameters that might be used as, for risk stratification in those patients before intervention. We are now working on some of the, as a sub-study on some parameters. One of them shows pretty convincing results as a marker of risk stratification, but also global longitudinal strain, also BMP. These are all good markers that might be useful in risk stratification, and especially MRI with regard to this. And with regard to our results, well, in general, those are in our cohort. Those are patients with good left ventricles. The volume might be maybe a little bit higher, but the general all other parameters were within normal range. So does that made any difference with regard to the outcome in the conservative treatment group? I don't know. I'm not sure. This one of the we have several limitations. One of the limitations is that the trial was relatively small. We have stopped it before we have included all patients that we were intending to include. However, from surgical point of view, you might know better than me. It's not easy to include asymptomatic patients in randomized surgery trial, and the other option is to send patient home and tell him come back in 6 months. So we did have some difficulties in regard to that, and maybe these numbers would be even more. This is just speculation, but maybe these numbers would be even more convincing that if the trial has reached all pre-specified 300 patients. But again, with regard to risk stratification, we already have some parameters that are good, that have shown good correlation with future adverse events and with the outcome, and we'll have some more. I'm expecting to be shown in the next couple of months, and that might be helpful when thinking about these patients. But let me just add, we should look the results and the treatment in asymptomatic patients with severe aortic stenosis now as a totality of evidence. So we have our trial. Before our we had the results of the South Korean trial, and we have also the number of observational studies that have been published in several meta-analyses. They were all heavily biased, but they did give us some clue and some indications that early surgery might be beneficial. So I think with now looking at the totality of evidence, if you have a patient that comes to your office who have severe aortic stenosis without significant comorbidities, based on all of this, you won't be wrong if you recommend him to go to the aortic valve replacement, surgical aortic valve replacement.
I also have one more question, just like a detail. I mean, it's very good. I'm very happy that the results were in favor of surgery, but the MACE was quite similar at 6 months at the beginning, even for, I mean, within the both arms, yeah? So I was just wondering if the control arm, the conservative patients, were they treated with optimal heart failure therapy? Because the MACE was actually driven mostly by the heart failure, right?
Yeah, well, they have received the heart failure therapy after they showed signs and symptoms of heart failure, not at the beginning because they were asymptomatic. So okay. After there was, and we had in the conservative treatment group, we had a total of 9 patients who developed heart failure during follow-up. Of these 9 patients, 8 went to the surgery. So they were operated because they had obviously symptoms of heart failure, of which 2 have died, and the other remain uneventful during the further course of the study. So all the patients, once they have shown signs of heart failure, they have received optimal medical therapy for heart failure, but not before that, because we didn't have reason to treat them for the heart failure because they were asymptomatic.
But a quarter of the patients, Marko, were on diuretics, but was that for hypertension, not for heart failure symptoms?
Yeah,
obviously.
they were, for the hypertension.
Okay.
The vast majority of patients had hypertension as a comorbidity or risk factor.
Well, I think it's really important take-home message. Aortic stenosis is a well-documented cause of myocardial fibrosis, which can develop before patients get symptoms, and myocardial fibrosis can be a cause of sudden death through arrhythmias, or obviously when it becomes progressive, then become a cause of heart failure. And once the patient has reached heart failure, then they're probably too far along in the disease process. So it's an important message for everybody that at least for surgery, we do have an indication based on this trial and the Korean trial for severe and very severe asymptomatic aortic stenosis. That data is still not there for TAVI, although there are, as I said, several trials working on this, and obviously a lot of industry support to push their therapy as a possible solution for asymptomatic aortic stenosis. So we're eagerly awaiting the results of those trials.
I fully agree, and I wish just once more to emphasize, I think it is important because, looking at the real world scenario, if early TAVI comes positive, then the majority of physicians will refer their patients to TAVIs and not to the surgery. That's real life. But I think still it does have to be compared. Regardless of positive, let's say hypothetically positive early TAVI trial, I think surgical aortic valve replacement should be considered as a gold standard, at least until proven otherwise. So we will need, because those are, those younger patients, they also have mechanical valves. Some of them also have biological valves. So we will. That also has to be compared during the long-term follow-up, at least at 10 years. So these are going to be important questions for those patients.
And
if you have,
Sorry for interrupting, Marko, but your study was also investigator-initiated, right? It's not.
Yeah, it was investigator-initiated. It was based mainly on the enthusiasm of people who were involved. But we are thinking about continuing, maybe starting another trial, which might be kind of looked at as a continuation of the AVATAR trial. We also are continuing to follow up AVATAR patients, and we will publish the results at least when every patient reaches the 5 years follow-up. So we will have 5 years follow-up for each and every AVATAR patient. So we will see how results develop in next. It should be finished in 2025. So we'll see that. But also with regard to this, I think there's still a lot of questions to be compared and answered.
Well, we're looking forward to hearing those data when they're available. Marko, are there any questions from anybody else? Doesn't look like we're getting anybody else asking any. Marko, I think we'll let you get to your dinner or get home, but we really appreciate you taking the time to speak to us here this evening. Matteo, do you want to say the last word?
No, I just wanted to thank you again. And I know it's a holiday for you today, so enjoy your free day.
Today is not a working day here because of the May the 1st. It's still reliquia from the older times. Nevertheless, I enjoyed. Thank you very much for inviting me. And I hope there will be in future some more opportunities to speak with you and maybe collaborate or whatever.
Definitely. Thank you, Marko.
Thank you.
Have a good evening.
Thank you very much. Thank you. Bye.
Thank you, everybody.